In today's lesson, we are going to talk about cancer of the pancreas. And when we say cancer of the pancreas, we have to emphasize that we are looking at duct adenocarcinoma of the pancreas. We are not including the neuroendocrine part of the gland. Pancreas is a composite gland, which part of which is similar to the salivary gland that secrete the lipase, amylase, peptidases, and other enzymes that help to digest lipid proteins, high molecular starch, and DNAs. In addition to that, there are the islets of Langerhans, and they have got neuroendocrine cells. They belong to the big neuroendocrine part of the human body, and some of them secrete insulin, others secrete glucagon, others secrete somatostatin, and variety of other, or gastrin, or variety of other hormones. The lesson today will be solely about cancer of the exocrine part of the pancreas, which is duct adenocarcinoma of the pancreas. It's very important to emphasize that cancer of the pancreas is a prevalent worldwide disease, affect people in their 60s to 70s, but there will be younger people, even in their late 30s or early 40s, who could get pancreatic cancer. The problem with pancreatic cancer has been is the lack of progress in treating the cancer on the medical front, which is the chemotherapy and the biological treatment that had progressed in the last few decades with breast cancer and bowel cancer. The only thing that might have improved things in the results of the surgery for pancreatic cancer, and by improving things, we mean long-term survival, is the adaptation of neoadjuvant treatment and safer surgery and availability of interventional radiology. But no major breakthrough has happened for quite a while. As a result of that, people with cancer of the pancreas, they will continue to die, and their prognosis will remain poor without any new discoveries in the next few decades. So in the year 2030, cancer of the pancreas will be the second cause of cancer death after lung cancer. The risk factors that can lead to pancreatic cancer, the important one of them is smoking, and smoking is the only preventable risk factor for pancreatic cancer, and a significant proportion of patients with pancreatic cancer are actually smoking, or they have been smoking for a long period of time in the past. People with diabetes, obese people, older people in their 60s and 70s, people who had chronic pancreatitis, they all have the risk to develop cancer of the pancreas, more than the average risk. There's only 3% of the total population of the patients with the pancreatic cancer who can actually inherit a faulty gene that lead to pancreatic cancer, and these are patients who inherit genes like the p53 or the familial mole melanoma syndrome related to p16 mutation. Patients with Peutz-Jeghers syndrome will have a higher risk. Patients with inherited idiopathic familial pancreatitis, they have a higher risk. And there are miscellaneous, such as the one of the BRCA genes is supposed to increase the risk of pancreatic cancer as well. Now, in terms of their presentation, patients usually come to their doctor having a bit of abdominal pain. The pain is epigastric. It's a double ache that shoots through the back. Very often, at the same time, they would report some lack of appetite, weight loss, and fatigue. Unfortunately, these symptoms are non-specific and they can be missed early. And my message to you in this situation is that if you see a man above the age of 50 with new onset epigastric pain, you need to do an ultrasound scan to rule out gallstones as a cause. If there are no gallstones, take it seriously. They need a CT scan of the abdomen and tumor marker in the form of CA19-9. Patients whose lesion is close to the bile duct and has infiltrated the bile duct mean that they will develop jaundice. In fact, these patients might be a lucky group of people with pancreatic cancer because often the jaundice will develop when the lesion is still less than 2 centimeters, which means it's not too advanced. And if they present at early stage, their benefit from the radical treatments will be a lot better than patients who present with a mass that is over 3 centimeters or there are local lymph nodes involved. Occasionally, people get admitted with acute pancreatitis, and on workup, we don't find a reason, and as a result of that, we scan them and we find a lesion in the pancreas, and on further investigation, we'll find it's malignant. There is an important point about people who have new onset diabetes. Any patient above the age of 55 who develop diabetes at that age, they need to be followed by their family doctor for a short while because they are at risk of having pancreatic cancer. And in fact, sometimes the diabetes itself is the first sign of the pancreatic cancer. So they need to be followed up with regular blood tests, tumor markers, liver function tests, and also a CT scan of the abdomen. And that could be done on annual basis for the first few years where the highest risk is. Pathology of the cancer of the pancreas, it's duct adenocarcinoma that arises from the main pancreatic ducts. And the cancer of the pancreas tend to generate a lot of desmoplastic reaction. The cancer by itself has got an aggressive biology. 70% of the lesion arises from the head and ancillary process of the pancreas, and the mode of spread is lymphovascular, as we know, local invasion, perineural invasion, which tend to be a poor prognostic sign. And also they do transcoelomic spread, where they fill the peritoneal cavity with cancer nodules that will lead to ascites and occasionally bowel obstruction. An important hypothesis in the development of pancreatic cancer is the fact that it does something similar to the adenocarcinoma sequence in the colon. It follows the same principle, but you don't get actual adenomas. You get what we call pancreatic intraepithelial neoplasia, which is grade 1, 2, 3, mild, moderate, severe dysplasia, or carcinoma in situ. You need multiple genetic mutations before you get to the level of the PAN-N3, which is advanced, and it's likely to cause invasive cancer. One of the very first mutation that will happen, it will happen in the APC gene, Adenovirus polyposis coli. One mutation that will lead to an early adenoma. Then you get the KRAS mutation, or the BRAF, or both of them. and that will lead to an intermediate adenoma. That's how it is described. And this process, up to here, it will take something like 2 to 5 years. Now, there is a sinister mutation that's going to happen here, and that usually happens in the SMAD4, used to be called deleted in pancreatic cancer gene, the SMAD4 gene. And another one might happen along that, which is the CDC4. That will lead to formation of a late adenoma. This is high-grade dysplasia, now nearly 5 years. By the time the patients have symptoms as a result of an established cancer, that would minimally be a centimeter or so, and more often around 3 centimeters, the symptoms will start. So it shows you that the period of time that there is from the first mutation until the cancer gets presented is nearly 10 years, 7 to 10 years. Now, this theory and this conclusion is based on animal studies and also on epidemiological studies, on autopsies to compare the median or average age of people who die from other reasons and they have PAN in 2 or 3, and those who develop pancreatic cancer. Now, some of the cancers will have also mutation of the HER2 gene, which is the related to the epidermal growth factor, and it's similar to the one that occur in breast cancer. So it's essential at your stage is to know at least these, because in any average pancreatic cancer, the number of mutations when the cancer becomes established will be more than 60 mutations. Now, once it reaches to a stage of invasion, the growth curve becomes exponential. So it goes up steeply and expand and start causing symptoms. So now you've got a patient, he's got epigastric pain, or he is presented with jaundice. Let's stick to the jaundice because it's a clear way of thinking about what we are going to do. So the patient presented with jaundice, they're likely to have other symptoms if you ask them, like the lack of appetite, weight loss, and the rest of it. We obviously here are going to check their bloods, and their bloods will be in the form of full blood count, UNEs, LFTs, and we will do coagulation in this situation because they are obstructed, and we will need to do tumor markers. Generally, when we do tumor markers, we specifically look at CA19-9. This is a carbohydrate antigen that is specific to the pancreatobiliary epithelium. It goes up in any neoplasia or damage to happen to the pancreatobiliary epithelium. It's non-specific. Its most benefit is, in fact, in the long-term progress in the follow-up where we do it on frequent basis to see if the patient develops metastases or not. And then we will do the imaging. Now, when we do imaging, initially, most of the time, we will find that people will get an ultrasound scan for the biliary tree to ensure there are no stones, because people with jaundice, a significant proportion of them, they will have jaundice because they have stones in the bile duct. So it will be worthwhile ruling that out. And then they will get a CT scan. The first CT scan is usually a portal venous phase, CT, chest, abdomen, and pelvis, and then we do a pancreatic protocol CT scan as well to show us where the mass is, what the size is, how it is affecting the bile duct, is the pancreatic duct dilated, and also its relationship to the adjacent vessels. which I will elaborate on in the next few slides. Endoscopic ultrasound and fine-needle aspiration is a pretty good investigation modality that has matured in the last 2 decades, and now most of these patients, they will go and have that, and this will give us the luxury of getting fine needle aspiration or even a biopsy from the pancreas to have a solid proof that it is duct adenocarcinoma of the pancreas. And once we've done that, if they are jaundiced, these days what we do, they go to have an ERCP and we put a stent. There are a variety of stents. You don't need to get too concerned about that at this stage. So now the CT and the PET, as you see here, there's a mass in the head of the pancreas, which is where the arrow is on the mass. The pancreatic duct is dilated, and that's typical for pancreatic cancer. It will cause obstruction and upstream dilatation. The bile duct is massive as well, so dilated, and also you have intrahepatic biliary dilatation. But there are no liver metastases. And this is a typical appearance of the PET scan, the FDG PET that we use. Avid lesions like cancer of the pancreas, they will be brighter than the rest of the body, and we do measure the luminance of that by SUV max. The radiology will measure that for us, and it does give us an idea about the metabolic activity of the cancer. Normally the kidneys will look the same, but the kidneys deal with the radioactive contrast and excrete it. Same thing with the heart and the lungs, and heart and the brain, and then the spleen. So these organs, FDG scan, tend not to be useful. The benefit of the PET scan is not to show us that, because we know that does exist. The benefit, though, is to ensure that there is no metastases, be it in the liver, in the lung, in the bones, or anywhere else. Because if it shows metastases, then we know that the patient has got advanced disease and they will not benefit from a radical form of treatment. Good. Now, once we looked at these patients, the results of the evaluation, we will go through the possible scenarios that will arise from our previous discussion. You will find that almost 80% of people who present with pancreatic cancer are not suitable for surgery and not suitable for any form of radical treatment. These are elderly, frail, younger than people in their 50s and 60s, and they could have severe comorbidities. If they have smoked for most of their life and they've got emphysema and ischemic heart disease, pancreatic surgery is very complex with high risk of complication, and we tend not to offer patients who are frail or have multiple organ problems, severely comorbid. Now that gets judged by our anesthetist team, who have a high-risk anesthetic clinic. These patients go in there and get assessed, and if the risk is prohibitively high of mortality and morbidity, then we advise them against the operation. Or we have metastatic disease. We find metastatic disease on the PET scan or the CT, and that, as I said, could be in the lungs, the liver, or the bones, or elsewhere. And we have to consider patient choice. People at stages, I see people who are suitable for all form of radical treatment with the chemotherapy and the surgery, but they are still reluctant because for a variety of personal reasons. They might have seen a family member who had the same problem and they didn't do well, or they saw someone having chemotherapy and they had a rough time with it. So we leave that to the patients. The other group of people are the patients who are suitable for radical treatment. Now, they have no metastases. They are medically suitable for major surgery and general anesthesia. In this particular group of patients, I do still need a little bit more of information before I can go ahead and talk to them about the operation. And this is what we call the local staging of pancreatic cancer. You don't do that for other cancers. It is something specific to pancreatic cancer. And the things that we need to know is the size of the lesion. Now, we know retrospectively that people who have got tumor that's more than 3 centimeters is T3. They're likely to have lymph node metastases, and they're likely to recur in the future. So they are kind of high risk group for recurrence. It doesn't stop us from offering them radical treatment, but still we point that out to them in order not to build false hopes. I want to look at the scan as well to see whether there is any evidence of local regional disease. And when we say local regional disease in cancers, we mean lymph nodes around the vessels that drain or supply the pancreas, which will be retropancreatic lymph nodes along the common hepatic artery and lymph nodes in the hepatoduodenal ligament. Our radiologists are really good, and we'll be able to look at the size of the lymph node as one of the criteria, the shape of the lymph node. Normal lymph node is oval, usually not more than a centimeter. Malignant lymph nodes are circular. They could have irregular borders, and if we see that, we start suspecting local regional disease. Now, local regional disease tend to make the prognosis worse. And then we move back to the cancer itself, and we examine closely the relationship of the cancer to the superior mesenteric vein and the portal vein. Now, if that's involved, I won't go into too much details about that, but if they are involved, it doesn't mean that we stop or cancel the operation. We will still be able to resect and do resection of the part of the superior mesenteric vein and the portal vein, and we harvest usually a right internal jugular vein as a conduit. Now, arterial invasion. The arteries that can get involved in the vicinity, they are the SMA, the common hepatic artery, the gastroduodenal artery, and the splenic artery. Now, splenic artery, if it is invaded and you got resectable cancer on the distal part of the pancreas and you want to do a distal pancreatectomy, if in a suitable patient, we would still do the operation because the spleen will be removed, and if the splenic artery involved, it will come out with the specimen as well. Now, the classification of arterial involvement tend to be a bit confusing, so it will tell us whether it's 180 part of the circumference, or 270, or 360. My general principle is that if there is a question of arterial involvement, I would say the disease is advanced, and if they don't understage, or downstage rather, with the chemotherapy, I would not operate on them. Which means that if you've got arterial involvement, regardless of the extent, we likely won't offer them surgery, because we will have a higher risk of ending up having a positive margin, and a positive margin with pancreatic cancer is bad news. And also the fact that removal of the artery, it has been done in the past, but the results are not encouraging. So we generally don't do it. I want to see the level of their CA19-9. So anything more than 500 make you wonder whether the patient has got metastatic disease. Ideally, people who do well tend to have their CA19-9 below 100. I also want to look at the patient themselves and how they are doing it, how much weight they have lost, so we can establish a baseline and then we see whether they will stabilize, will they gain weight on chemotherapy, will their weight continue to go down, because that is an important piece of information that will help me make a decision. Now, if we decided that the patient is resectable or potentially resectable, which means that we're not 100% sure about the vascular side of the problem, then they go and have 4 cycles of neo-adjuvant chemotherapy. It's heavy chemotherapy associated with significant side effects, and variety of regimes have been used. One of them is famous, it's the FOLFIRINOX. The same thing is used in metastatic colorectal cancer. We have got paclitaxel is being used increasingly. Also gemcitabine in the form of tablets. We don't deal with these things, so we leave any discussion or relationship with the chemotherapy to the medical oncologist to go over that, to inform the patient about what they expect, the side effects, the benefits, and the duration of the treatment. It goes into cycles. Unfortunately, there are molecular agents that have helped to treat people with melanoma, lung cancer, and breast cancer. 1 or 2 of them have been tried in pancreatic cancer, but they did not prove to be of any benefit. One of them is called panitumumab. You might ask about the role of the radiotherapy. Should we give them radiotherapy at any point in their treatment? Now, radiotherapy has been used here and there, and the use has been patchy, and the results are equivocal, and it hasn't been proven to prolong patients' survival. Did not contribute to the radical therapeutic treatment. That's why we don't use it routinely. It could be used in patients who either have recurrent disease or irresectable disease, where they have agonizing pain because the cancer has invaded the celiac plexus, and the pain that arises from that is intense and affects their quality of life badly, where they can have either radiation or some other forms of treatment, such as splanchnic or celiac plexus block. Now, once they have their chemotherapy, we give them 4 weeks of rest, and then we do a CT scan, a PET scan, we repeat their CA19-9, and we look at their body weight. The best patients who will do well are those who have morphologic response on CT. The tumor is less in size. Metabolic improvement on PET, which means that the SUV max has been reduced. CA19-9, a biochemical response, which means that whatever pre-treatment CA19-9 was, now it's coming down at least. well, or stable or at least or coming down. And we want them to be either half-foot weight or their weight remains stable, and we want them to be positive and determinant to have the operation. It's a pretty big operation with very high risk of complications. So I generally ask the patient many questions to ensure they're not going to fall apart emotionally after the operation, which has happened in the past where they just turn their head to the wall and they just die, basically. So you need a positive mind, determined person who will stand in there and tell you that they want to put up a fight. If we are all happy and we think it's a goer and patient is still willing, then we offer them surgery. And the surgery for cancer of the head of the pancreas and the incident process is called the Whipple operation. And the Whipple operation involves removal of the head of the pancreas, the entire duodenum, about 15 centimeter, also from the duodenum. We take the gallbladder, we cut the bile ducts below the hilum, and I do a classical Whipple, which means that I cut the antrum of the stomach. And then we do a few anastomoses. Let's not get into the details of that because it could be confusing. But I need to emphasize on the enormity of the operation and the fact that it has got 40% risk of having major complication, and almost 80 will have some sort of complication. One of the dreaded things in pancreatic surgery is the fact that your pancreatic jejunostomy could fall apart, and that's called postoperative pancreatic fistula. Now, it comes into several grades. If it totally fall apart, then it's and the patient have collections and things that need to be drained. This is grade C. Grade B when it's minor and there's no much intervention that need to be done, and grade A when it is only elevated lipase in the drain with no clinical consequences. Anyway, so that can happen, and the risk of leak from a Whipple operation is somewhere in the region of 15 to 25% of the cases. I had two cases where they had chyle leak, which meant that we can't feed them, where we fed them with the median chain triglycerides, and the median chain triglycerides are absorbed by the by the vascular system into the portal circulation, and they do not get absorbed by the lymphatic system, in contrast to other forms of fat. We did them, and almost every one of them settled down on such treatment in about 6 weeks. It is a possibility that you could leak from the other sides of the anastomoses, because in total, usually I end up having 4 of them. But that possibility is very small, and the treatment for that tend to be easier. Now, going back to that for a second, I want to emphasize a point. One of the dreadful complications that could happen after a Whipple surgery is that and that happens when you have a pancreatic fistula, is that the pancreatic enzymes could actually digest the stump of the GDA. And as a result of that, you could have false aneurysm or severe hemorrhage. Mortality rate is quite high with that. And if anyone dies from pancreatic fistula, it would be those people who would have bled from the gastroduodenal artery, because what the leak does, or the fistula does, it makes collection in the abdomen here and there where you can drain them. But if they are close to the HGDA, they're just digestible and they bleed. And typically the patient will come to the hospital with a small bleed, a herald bleed, and after a few hours, there will be a major catastrophic bleed with a high mortality rate. Now let's assume that we did the operation, patient didn't do too badly, and went home, and they are asking you about how well do you think they will do in the long term. Do you think you got all the cancer? Is a common question. These things tend to be tricky to answer because cancer in many patients at the time of the diagnosis should be considered as a systemic disease, which means there are microscopic cells elsewhere in the body that will cause the recurrence of the cancer. And that's the rationale of the neoadjuvant treatment. In addition to its ability to downstage and increase resectability, it will also kill any cancer cells outside the pancreas. We know that the majority are unresectable. We tell them that, so they understand they have a better chance than others. The median survival, unfortunately, is still around 24 months with all the radical treatments of the chemotherapy and the surgery. 5-year survival has improved slightly in the last decade, and but still it is about 25%. There are centers who reported somewhere between 30 and 35, but these are big centers. The patients are well chosen, and most patients who get resected are T2, which means that the lesion is below 2 centimeters. Obviously, after you resect the specimen, you need to go back and talk to the patient about the finding from the histopathology. And the points that will determine or have an impact on the long-term prognosis are the following. The size of the tumor, is it T2 or T3? Big difference. Were there any lymph nodes involved? Has the disease gone to the lymph nodes? Now, if it is 1 or 2 lymph nodes among 30 lymph nodes, it might not be as a disaster, but if you have 15 or 16 lymph nodes and half of them are involved, I mean, almost certainly that recurrence is impending, and it could happen within 3 months. And the usual recurrence will appear in the liver or the peritoneal cavity or the lungs. So we focus again on margins, lymph nodes, size of the tumor or the T stage, presence and absence of lymphovascular invasion, and paraneural invasion tend to be more nasty than the vascular invasion. And the grade of the tumor. So the grades of the pancreatic cancer are grade 1, 2, 3, well differentiated, moderate differentiation, and poorly differentiated. There are unfortunately also weird histologies, and they all tend to do bad in the pancreas if they happen, other than the duct adenocarcinoma. And majority of them, you won't find about them unless you do a biopsy prior or only when you have your pathology report back. Adenosquamous carcinoma, they don't do well, it's very aggressive. Sarcomatous variant, they are very aggressive. Mucinous type of adenocarcinoma. I'm not sure if there is much difference between it and the conventional duct adenocarcinoma. And I had one patient who had a small tumor, and we were all hoping, and so we operated on him, did extremely well, and he was 80 years old. And when I got the results of the pathology, it was small cell cancer, which is one of these high-grade neuroendocrine tumor, grade 4. And small cell neuroendocrine tumor of that area, the lesion was in the periampullary region. Because I've never heard of it by then, I looked up the literature, and I found no survivors have been reported beyond 6 months for this type of histology. And sure enough, he came back 3 months later on with a small bowel obstruction, and a CT scan showed some deposits in the abdominal cavity and elsewhere. And he survived about 5 months or so. So in general, the median survival is 24. That the patients need to know that, because that's the median. That's the most likely that everyone will get. But we ask people who have recurred after the 2 years and had minimal 2 years after the operation, and they all seem to be grateful, and they think it's worthwhile going through that problem. Now, how do we follow them up? We discussed them after that in the MDT meeting, and some of them will need, or as part of the treatment, usually they will need some more chemotherapy to consolidate the benefit they had from the neoadjuvant treatment. Not all of them will be suitable for that, but it has to be discussed with the patient and with medical oncologists. Now, 40% of these patients will need enzyme supplements in the form of a capsule called Creon. 20% will have a new onset diabetes. Usually they manage that with no major difficulties. They will have functional gut complications. And the functional gut complications, early satiety, poor gastric emptying, particularly in the first 3 months, abdominal cramps. They could get even dumping syndrome, similar to the gastrectomy. So we get them to see a dietitian, and in fact we link them to a dietitian before the operation to prepare them as to what to expect after. And as far as the cancer is concerned, we do CA19-9 every 3 months. Do CT scan at 6 months after the operation, and then at every 6 months for the next 5 years. While we are doing this follow-up, inevitably, some people will develop recurrence. So we send them back to the medical oncologist to consider them for a possibility of palliative chemotherapy. Well, friends, thank you for listening. It would be great if you could interact with us by sending us your comments and suggestions. And let me know if there are any burning topics that you want us to do in the immediate future. I'm going to write these topics, hopefully my time allows, and so I can do them on a regular basis. And we are here trying to cover all aspects of general surgery. I'll see you in the next lesson.